Okay, so thank you, Professor Natarajan. So I think we listened to really great talks today. I think just a really nice global perspective and also highlights a lot of common issues that we have. I think what the COVID-19 pandemic did was not only did it increase certain types of trauma that we've seen, like domestic trauma, and in some cases even sports injuries because of finding things to do. But I think it also highlights also some issues that COVID has caused in terms of lack of access to care or unwillingness to get timely care. And it's also impacting our training and also even for surgeons who are established, who are already operating on their own, it's just losing the practice, losing the groove, and losing their surgical skills as well. So, yeah, Dr. Rupesh, do you have anything you want to add in terms of starting the panel discussion?
Yeah. Thanks, Kendrick. And I'm really thankful to all the speakers. I really thank, first of all, Professor Ganga for setting it up. And this is really having all the speakers from all over the world. So I think, as Professor Fountain did mention about having those African ophthalmologists in US, and none of the ophthalmologists is probably completely trained about the trauma. So I think that goes to a fundamental question to almost all the panelists here, and which Professor Ferenkun has been talking from 1992 probably, is about imparting the training to the fellows or the colleagues or the residents about the trauma. And if you submit a paper on American Academy platform also for a free paper submission or a poster, you don't even find a tab of trauma. There is no separate category or section of trauma there, whether it is EVRS or whether you talk about any of the other platform. Hardly you will see, and then the trauma you have to fit it into general ophthalmology or vitreoretina or neuro-ophthalmologist. You tell me how many centers are there in the world with a proper trauma center with the trauma fellows. So I was the one fellow with Professor Ganga and inspired by Dr. Natarajan, and who did only trauma in my life, and probably more than 1,500 cases of trauma management I did. I did some bit of orbit, but we could not manage to get that trauma fellowship there. So what is the stand of all the different continents about creating a trauma fellowship program? We don't have at all over the world. So that's my first question. And at this level, probably all the leaderships are here. So many presidents are here. What are your thoughts on it? How do we move forward? Because we have heard about it. People speak about the challenges, which is the lack of training, lack of motivation, lack of SOPs, lack of structured training program. But we need to probably take a stand at this stage. How do we take it forward? So I have been demotivated for many years now. There is no support for trauma, no incentive for doing trauma. How do we take it forward? Because we will be having this symposium time and again. But unless we come up with a training program, whether it starts from AO or whether it starts from RENSCO, I have spoken to AO, I have spoken to RENSCO, but nothing has moved forward. So just your thoughts.
Yeah, but we have a Ferenc School here.
Yeah.
And we have Tamara, I think, and also Hugo made a presentation on Petit and other programs where Hugo.
Hey, Professor Natarajan, we have iGates program also. We have a trauma registry. We have created that. So the registry has been there. USCIR been there. How many people take it up? Ocular trauma score has been there. How many people really take that? None of my residents know about using ocular trauma score. And it's like cataract, people will know everything. Retina, AMD, they will have all the things. But we don't have that thing for the trauma management. So I think, how are we going to structure it? And at this level, we need to probably think about how are we going to define the trauma in the next 5 years. So it does not be ASOT. So I think everyone need to join hand together. When the ASOT was formed, APOTS did suggest it, APOTS, ISOT, ASOT, everyone need to collaborate to take it forward. How do we take it forward? So that's the most important thing, is the skeleton. If we can come up with a skeleton, then we are ready to kind of take it forward. I've worked with Grant Justine, we are working with Fasika. We are ready to take it forward, but we just need to...
Let's hear from the masters, Professor Ferenc Stone and Dr. Jose Dalma, please.
Appreciate the session, and Tamara can follow up with all of our other presidents. The Ferenc?
Well, I think this is really the main question. How do we teach the next generation? And I see several problems here. One of them is, as we heard in a number of these wonderful talks, the lack or the inappropriateness of teaching, not enough teaching, not enough opportunities to learn trauma care. And Professor Talma's talk had a very important line in it, which said, and this is why I'm mentioning it to add another layer of the problems to this, is that in South Africa, at least, the ophthalmologist who treats trauma treats a lot of cases. So it's not a lot of people doing a few cases, but the other way around, which is the ideal. It should be the experienced one, not the resident who was not trained. So my addition to the problem is those who are training, are they trained themselves? Because I have certain doubts when I travel around the world, used to, and I go to ORs and talk to people who are supposed to teach or even teach, and then I ask them a few questions, for example, as Gary mentioned, about suturing. Who the hell is teaching suturing today? The answer is almost nobody. So the only goal of those who do the primary wound closure is to have a watertight wound. Of course, it's important, but is it sufficient? Obviously not. So I wish I could have an answer to this. Trauma fellowships would be a very good solution, but we have to be realistic. And this also came up a lot, funding. Who will fund a trauma fellowship, which, as we know, in most cases must involve other things as well, not just trauma, because in most countries in the world, you will not be able to supply enough material, fortunately, for somebody doing only trauma. And also, nobody should be doing only trauma because you have to do other things to keep up your skill level, etc. So we also know, if you go back and look at the ISAT meetings that I was involved with, it used to be a standalone ISAT society meeting, but in the last, I don't know, 15, 20 years, you could not organize one because you would not find sponsors. There's no money in trauma for the companies. So they will only come if you work together with another society and the financial support comes to the trauma part of the meeting through that other society. So I'm sorry I offered no solution, just a few thoughts. But let me finish with another thing which already came up, and I want to emphasize this, and that goes back to the American Academy. We have been trying for many, many years to make trauma a standalone subspecialty, and obviously we have not been successful. So, for example, if you submit a course to the Academy for this year, as in the past years, there is no trauma topic that you can choose. You have to go with anterior segment, something, or retina. And it may be true for certain traumas, but most of them, because trauma cuts across all subspecialties, you have to force your talk into something, some category which doesn't necessarily fit. Also, the Academy doesn't have a standalone book on trauma management. The posterior segment is hidden in the retina section, the anterior segment trauma in one of the anterior segment books. So by doing a standalone trauma, we not only give more accurate categorization, but also emphasize the need to have it as something that people have to be trained for.
If I may, most of us that are here in the panel have taken trauma more or less as a hobby. I mean, we're here. None of us is a professional. Well, at least most of us are not a professional, exclusive trauma surgeons. We do trauma basically as a hobby because nobody will pay for it. Unfortunately, the hospital systems around the world are not geared to pay a permanent staff trauma surgeon to be on call. No, it just doesn't happen. At least in Latin America, the way the systems work, I only know of one program in Guatemala that actually funds a special physician to deal with trauma 24 hours a day, 365 days a year. That's the only program I know. here in Latin America that has that. So as long as a physician cannot make a proper living doing exclusively trauma, none of these initiatives will work, because somebody has to make a living out of this. So unfortunately, if there's no money, if there's no investment in this by the hospitals, by the government systems, it's going to be tough to have it as a subspecialty.
I think one of the things which Professor Huayan showed at the beginning of his talk is a very beautiful video by Bill Gates, is about building the systems. I think we are talking now about the coronavirus pandemic, and we are already talking about having the systems in place. So this trauma, according to me, is an ongoing pandemic for many, many years. And we've been talking about it. So I think, as Professor Dalma rightly said, if we need to build up a system, I think we need to put up things like, we have to come up with some solutions, whether it is to be blended with oculoplasty with trauma, or whether it is to be general ophthalmology with trauma, something like that. Some creativeness, some innovativeness has to be done. Otherwise, we'll be still talking probably the same thing. So some systems need to be created if we are not going to repeat the same symposium after 5 years again. Yeah. Yeah. You
Yes,
need to.
Dr. Tama.
Yeah, wait. Wait, Professor Tama.
Rupesh?
Yeah, Professor Huayan, just a second.
I want to say, I have a little bit to talk. So just now, Kun gave us a good idea. So I think for the next generation, for the young residents, how to train their ocular trauma surgery or diagnosis or treatment. From the presentation of the president of AAO, and told us, in different countries, the ocular trauma cases are different. So if they are different, so I have an idea. So APOTS, like a good organization, like a good team. So all the young residents in the world, if they want to get the training of ocular trauma, they can apply for this to the APOTS. And then almost the experts from APOTS can, accept some of them. And for me, if I like to accept one or two fellow for ocular trauma surgery training, I will, for call Rupesh, Ganga, Natarajan, I want to get one fellow for ocular trauma. And in my hospital or in China, I'm sure for the training fee will be free, and the fellow just pay the, for the room, for the flight tickets, like that. It's very cheap. So depend on their demand, Rupesh. So I think this is a good idea, maybe. Thank you.
I think that's a great idea. Sorry, go ahead. Go ahead. I think all of you have highlighted several things, and I think Rupesh and Dr. Ferenc Kuhn was pointing out that Academy did not have a trauma category, and we have been sneaking in our general ophthalmology section. And thankfully, the Academy has been accepting our courses and Dr. Ferenc's courses also over the years. But one major thing was it was always the last session on the last day during the era of physical meetings. Yes. And people are busy running around catching their flights. So I think one way is centering it somewhere in the beginning of the meeting, number one. WOC, when they conducted the ICO this year, they did manage to create a section on trauma. And believe it or not, it was one of the most well-attended courses, and we were able to submit a lot of courses. And we got speakers from around the world to join the trauma section courses at the WOC. So I'm sure the American Academy of Ophthalmology, if we have collaboration with the president, the CEO, and practically all faculty who do trauma, we should be able to create one. And the advantage of creating a separate category is the sponsors of the meeting themselves start taking note that it is one of the important sections, like retina, glaucoma, pediatrics, plastics, so on and so forth. And that could be an indirect route to sponsorship for future courses. And Professor Huayan mentioned about sponsored fellowships. We have APAO sponsored fellowships in various subspecialties where, like he said, institutions accept a fellow, we won't charge them for anything, but they can come travel on their own, stay on their own. We can train them. So likewise, we can have an APO-AO collaboration where these societies recognize centers of excellence with individual excellence in each of these institutions. So prepare to train a fellow. And we can have a global network where a guy from Singapore can go to Germany, a guy from France can go to Australia, accepted by a mentor who can train them and guide them in trauma. These are two suggestions which just came to me. Tamara, go ahead, please.
Yeah, I was going to step in here that I think as been described by everybody, it really comes down to funding on some level, whether it's government funding, whether it's funding for individual physicians to take call. You know, most of our level 1 trauma centers, you know, they pay call for many types of services, but it is really unusual for ophthalmologists in particular to be able to negotiate with their hospital systems for pay. And we are prevented from unionizing here in the United States. And so, you know, I think there's two parts of the problem is that we can provide all of the fellowship training, all of the education that we can muster, but at least in the United States, we still have the issue that our members, once they get that training, are going to be reluctant to provide it because trauma is so poorly compensated and it's so inconvenient. That's the reality. But you know what? You get what you pay for. And you know, neurosurgeons who are paid to take call, they're there. And no level trauma center can be a level 1 trauma center without that service. My understanding, and I'm not the expert here, is that while the ACS establishes what trauma centers should have in order to receive that designation, I don't know that there's any mandates for that. And so we have a fragmented system. We also are facing the reality that we have an entire DC office, Washington, DC office, dedicated to advocating for a favorable regulatory environment for our ophthalmologists, just to get paid to do cataracts and glaucoma and things in our offices. And so we are facing some headwinds going forward, even more so than usual because of the bill that all of our governments across the world are going to have to pay for the COVID coverage. So, you know, I listened to the discussions here and I know that it's always been challenging. It's going to be that more challenging at least in the next few years as our governments are distracted with issues elsewhere in our public health arena. But I think, you know, when I hear you all talk about, you know, the lack of a trauma silo at the academy, and I think about that, and I, you know, I may be the president, but, you know, this is a well-oiled machine run by David Park and our vice presidents in our San Francisco office. But it seems as I listen that it doesn't really cost that much money, if anything, to organize our academy meeting in a way that can provide a little more emphasis on the coordination and the collaboration that trauma involves, because it really does involve everybody from all facets of the ophthalmic sphere. And so, you know, I'm gonna talk with Dale Fajardo and see, you know, how difficult would it be to reorganize things so that we take trauma and give it its own home. I know you probably have done that, so I'm not going to act like I can do things that you all haven't done before, but I certainly want to partner and do what I can to help in that regard.
Thank you.
I think that's wonderful.
I think Dr. Tama would like to say something too.
Yeah. Could I maybe say, I think let's start off in terms of training. In the basic, shouldn't we start at piecemeal? We can't have a big bang created. Trauma is a multidisciplinary sort of treatment, I think, all over the world. So it's very difficult for one person to do everything. So therefore, I'm thinking it should be nearly a required add-on to each discipline, to the retinal surgeon, the anterior surgeon. So to have a component dedicated to, I'm just asking, to trauma. If we could have in our basic training the schedule of minimum requirements that must be trained for residents in anterior segment, in the iris, in the lens, in the retina, and the orbit. And one component should be it. And if we could have a work group creating such a schedule on what is the minimum required that should be exams, and there must be questions in the exams. And then we can add it to every subspecialty and fellowship, a small component that should be trauma related, because the principle, as Ferenc has shown us, is the same. And if we understand that and make it up, enforce it, then we're going to get much further. As far as funding is concerned, we managed in our country to make emergency treatment legalized, has to be paid by insurance companies and hospitals. So for us, the initial treatment, if you have an open globe, you fix it over the weekend, there's no problem in funding and payment. The long-term treatment might be problematic, but that's also legally already been included. So that's a good way of doing it, starting it on emergency. But I would really think we must have a stepwise, start with the training minimum, small component per discipline, and then we get our foot in the door. Thanks.
Yeah, so maybe I'll just share what Dr. Talma said and something which we have been talking about it.
A concept which will be looking like something like
sorry,
this.
This is the video maybe, but just wanted to stop video. Okay, basically, as we have been talking about the trauma unit, and what can be done there is to put this thought is any hospital should have a trauma unit. All the patients of trauma should go there. So I deal with other subspecialties uveitis, which is again a very small number of patients. So even if you start with all blunt trauma, open globe trauma goes to that, automatically you will see that clinic being flooded after the end of 3 months or 4 months. Probably he will be seeing 20 patients every day, because there will be some follow-up patient and some new patients. And that person of that hospital becomes the center person. And eventually he's going to triage the patient. So any patient with history of trauma goes to him as a fresh case or as a follow-up case, and then continue with it. After that, once it becomes more complex, whether it is traumatic endophthalmitis, blood fracture, or something else, then he lies with the other subspecialty colleagues. So that's how probably a care model can work. Probably Dr. Ginny wanted to say something.
Giampaolo wants to say something.
Oh, Ginny, go ahead.
Yes. Everything you said, I agree on. What I like to point out is that obviously different places have different realities. So, for example, in Europe, and I think in a lot of Western world countries, we are victims of our own success in preventing injuries. So there has been some very strict regulations with severe fines for not applying the rules on the workplace, so that now the number of injuries on the workplace has dropped dramatically. Now, that is something we all strive for, but we also are penalized by this, because obviously we lack the numbers of traumas that other people have, and that actually allow you to train. So that is one aspect of the question, and that would necessarily require having two different things. One is having obviously different sorts of training, and Gary was pointing out to a number of virtual models. I believe that Ferenc was saying something quite appropriate when he was saying people don't know how to suture anymore. Now, my trainees sometimes have difficulty just inserting a secondary lens because they don't know how to suture. They haven't been trained because they do phaco all the time. So it's necessary to go back to basics and to learn this. And you can do this on animal models very easily. This is what we all did before we started actually going on to human beings. So that's one aspect. Training doesn't necessarily have to be in the first instance on trauma cases, especially if you don't have the trauma cases. The second thing is that because certain countries do not have either the funding or the numbers to justify the existence of a dedicated trauma hospital within department within each hospital, then we should geographically organize centers which will serve wider geographic areas. For example, we can have one in the southeast of England, we can have one in the Midlands, we can have one in the north of England, and so forth. The same thing for Italy. So in our countries, the distances are not great. So you can go from Milan to down to Sicily. It's an hour flight, 50 minutes. So we can have lesser centers and well organized, in which you have properly trained surgeons. Another aspect, again, is that we are fighting against a consumer society, where, as Tamara was saying, people will go where the money is. It's most of the ophthalmologists. Why do a lot of ophthalmologists go from retina to well, not many that I know of, fortunately, but they choose refractive surgery? Well, because it's easy, and it's easier, and certainly more lucrative. So again, now the tendency is to have subspecialties. So people do only cataracts, only glaucoma, only cornea. Here we're talking about pole-to-pole surgeons, as we were. I mean, in my days, we did everything from and Natarajan, and Cesare and first, we did everything from because when you're doing a trauma, you can't sit and say, wait, I'm not going to take the cornea out and put a keratoprosthesis because I need the cornea surgeon. You don't have the cornea surgeon. You don't have the time. So you have to know how to do that, and so forth. So if you have to put in a valve because you have a traumatic glaucoma, you have to know how to do that. So we're fighting against a well-set standard ideas that we have to subspecialize. So the trauma surgeon is the opposite of subspecialties, because we do everything from pole to pole. So there are many issues to consider. Some of them are difficult to get around, and again, funding and political lobbying are essential to getting at least this speciality recognized and having a dignity of its own, because it does have a dignity of its own. But until we finally get the national societies and the political power behind that to recognize it. Now, Tamara was talking about the 1966 Safety Act for the highways. That came about because there was strong political pressure on the government to do something about those accidents. We had to do the same as far as eye trauma was concerned. We had to lobby. We have to get the government to intervene.
Those are really excellent points, and I think a lot of us to kind of take the points from this. And maybe, because I know this will go on for the whole night, but is it possible that we set up, and with due permission from APOTS president, we set up a task force, a global task force with some key members from all the different societies, and I did requested for it, and we continue to brainstorm it and come up with certain kind of a guidelines, because this is not going to be possible, and where we kind of find the challenges, and then what are the ways ahead. So what do you think, President APOTS?
I think we have 6 presidents here. We can be the whatever the supervisory whatever capacity. We're not really going to work as now. The whole program is done by all of you. We will come and maybe fine tune it, as Dr. Tamara presented a lot of things from academy, which was done for a lot of time. I think quite a good period of time the work has been done. Similarly, I think all presidents can head this, and we can have the global thing as task force, as you said, and from APOTS like you and Kendrick can be there, and from like that EVRS, from the APTO, then AAO and ISOT, I think we can have, and also from Hugo's place and South Africa. And Africa, I said a lot of vacuum surgery. When we are trying to do some rest of the world, I think we have to keep Africa in mind to pull them up to our level, so that we are all, as Ganga put it in the notes, that we should have a flat thing. So I think it's a good idea to have that from APOTS. I think you and Kendrick can be the 2 members to the task force. Like that, other 5 societies from China, 2 from EVRS, from AO, I sought, and we can select that.
Yeah, I think this is an excellent idea, and
Yeah,
while I
thank you.
hate
Thank you.
bureaucracy, but I think the reason to have all the possible societies sign up to it is because that would create the force for politicians to do something about this.
Yes, I think so. And I think the AO I sought from the Northern America, and then we have South America, and then we have Africa, we have APOTS, the entire Asia Pacific, and what is left? And China is there, another 1/4 of the world.
We need somebody from Antarctica, and then we cover the globe.
Oceania will be remaining. Last continent, Oceania will be remaining. But anyway, Dr. Ganga, sir, you have any further points? And because
no, we formed the global task force.
Yeah.
The president says you can call it the patrons or whatever, and
Yeah.
have a force of 2 from each. And then, as Ferenc says, under the 6 societies, all other societies has to be a associate where they can have academically oriented 2 ophthalmologists as a subcommittee with you, like ocular trauma, oculoplasty, vitreoretinal, glaucoma, whatever. Because I think, as Gianpaolo said, I think we 6 societies have to see the global, like I'm talking about the globe, the global ophthalmology, and plus we have that other societies joining us under us, so that we have a real global task force for the globe.
Sure, we'll do that. Sir, you're muted. Dr. Ganga, you're muted.
Sorry, thank you. So before I say anything, maybe I'll invite Professor Caroline Chi, Hugo, and Gary also to say a few things, what's on their mind before I just put about 3 particular points across. Caroline?
Yes, I was, can you hear me?
Yes.
Okay, I was actually starting to type out a suggestion, which was if we could look at the economic cost of loss of vision from ocular trauma and use those figures, so that data, to advocate for to our governments to provide financial support to institutions to be able to create positions for ocular trauma specialists, since that is really one of the problems to move forward. So really getting data on
in fact,
the economic cost to a country.
I think that economics and quality of life is the very key important thing, and I think that including that component will definitely give a bit of thing to regulatory authorities and the government.
In fact, where I mean, I used to say this with orbital
So
fracture.
I mean, if we get
Go ahead, Caroline.
I mean, if we get this from all the continents, I think that would be, I mean, I would imagine that would be pretty powerful.
Yeah.
Right. I think there are probably two arms to it. I mean, I used to say this with orbital fractures, that every single fracture we do and rehabilitate and send the patients back to the perfectly normal pre-morbid life, we say there's no residual mobility, hence there's no compensation. But that's a success in itself. And every single trauma which has been mismanaged or delayed managed, and the costs that you're talking about, I think both the success and failure have to be valued in dollar values. And that message has to get across to the societies, organizations, or governments. I think that's a very good point. Hugo, would you like to say something?
Yeah, thank you. First of all, thank you for this great opportunity to show to Latin America in ocular trauma. I'm very happy because here all the world talking about ocular trauma, and Ferenc says there are many different societies. I think this only one society with different names, but the thing, the ideas is the same, and this is very important. I think that we have a problem in all countries is that ocular trauma is like the Cinderella of the ophthalmologist. And it's very important to show the government how much the cost and a blind in a patient of, I don't know, 30 years, 20 years old, is very old, very high costs. If this is the great opportunity to show in like a unit how important is training our residents, our fellows in the appropriate initial management of ocular trauma. So thank you very much for this great opportunity.
Gary, would you like to say something? Because you seem to have a wonderful training program, and I'd like to hear your perspectives before I just summarize into 2 or 3 points here.
Yes, thank you very much. I'm driving in to see my post-op LASIK patients, but I can still, education is the key. Everything that's been mentioned, we need to continue to educate, teach the basics of trauma, go back to suturing and getting practice with suturing. The next thing is uniting our efforts, staying united. I was at the AAO when we were in person 2 years ago, and Society of Military Ophthalmology had a trauma course. Same with, I think, Mass Eye and Ear, and then you guys. So there's various trauma courses, but we should unite and be teaching the same principles, working together to push our efforts, and just appreciate all your help and let me speak here today. So yes, continue to take time to teach the residents and continue to be role models and examples out there. Thank you.
Great. So yeah, go ahead, Franz. Yes, please.
I want to add just 2 sentences. You were kind enough at the beginning to call me the father of modern traumatology. I appreciate that line very much. You have to change to grandfather. If what you said is true, then you are all my children. And I just want to say I'm very proud of my children, because both the organizers and all the speakers did a tremendous job. So congratulations to all of you, and thank you for the contributions.
You're still too young, so we cannot call you again grandfather, Ferenc. You're too young and too relevant. So no, I really am inspired by you, although I would strongly say that it's ocular, ophthalmic, these are all semantics, but we try to look at adnexal structures and we look at in unison. But I just wanted to get across these 3 points. Number one, we now seem to have a North American, or the American Society of Ocular Trauma, or ophthalmic trauma, which has been redesigned. There's Asia Pacific Society, there's a Latin American, or APTO, so to speak. Probably the 2 continents are Africa and Europe, which don't yet have trauma societies. And Ginny pointed out, it's a price they pay for the success. They've been reducing ocular trauma. But I think every country, every institution sees a minority of cases, but I'm sure if you put all your cases together, it's significant, and forming that society becomes an essential step towards better training, actually. So maybe I will probably extend on behalf of Professor Natarajan, Rupesh, and Kendrick from APOTS that we are willing to collaborate both with the European friends and the African friends to help form a special interest group followed by a society. So that's number 1.
Thank you.
And number 2 is, like I mentioned, at WOC, I think now Dr. Fountain has said she'll take it up with the Academy Education Committee to try to see. It should not be very difficult. Sometimes the egos are more difficult than the institution. And she's the leader. She's the leader. The leader and a friend. And with the vision that she has, having talked to all of us, to take the idea forward, in which Ferenc has been pushing for a long time, that try to create a section, and whether it's going to be anterior segment trauma, posterior segment trauma, primary repairs to orbital fractures and orbitofacial fractures, all that could be collated. And I think in trade and industry will look at that as a section, which hopefully will draw the attention for future sponsorship. And the third and most important thing is, Hugo talked about it, Gary talked about it, simulated training. Yes, we do not have that for trauma yet. And I think we come up with a modular system where we have globe repair training, lid repair training, and maybe a fracture repair training, which is now available for a lot of things. And maybe if you can, all of us share what are the models you're working with and what are the deficiencies that we have, and how we can collaborate and make sure that top centers around the world will have that as a center of excellence, will lead towards a curriculum for ophthalmic trauma training, which can be open to non-ophthalmologists, ophthalmologists, subspecialists, and eventually towards fellowship training. Those are the 3 things that I had. Thank you.
Ganga, can I make comments?
Yeah.
Yeah, so in continuation of what Giampaolo said, I want to remind, and I think Ferenc Kuhn also operates there, and I also operate in Lublin in Poland. There's an institute called the Ocular Trauma Institute, started I think 50 years back, right? Ferenc, I think that Trauma Institute is the building, no, the one where Dr. Robert Redak is there. And your friend is the retired professor. I forgot. I think it's a
Yes,
trauma.
but I don't know when it was established.
I think it's a very old building. Now they have moved to the new building. And it's in a trauma institute for several years. I think in Europe, there is, I mean, definitely trauma would have been reduced, but I think, as you said, trauma institute will be there. And I think you said me to give some, like the 10 years of experience of ophthalmic, the APOTS, and then 25 years of Ocular Trauma Society of India. So I thought by 2030, we should have prevention of ophthalmic trauma in a big way. That what I meant by big way is every leader have to have something written about prevention of trauma rather than only talking about doing repair of trauma. And the other is protective gears with world standard uniform to the whole world. I know I'm in North America. That means US and Canada has a standard. And when I tell the patients wear a protective goggles and play shuttle or badminton or tennis, and they say, where is it available? India, it's not there because we don't have a standard for that. And I think we need it for the whole world. And training residents, which you mentioned, and training ophthalmologists, not only residents, I'm sure who are in 5 years of practicing in rural parts of the, whether it's US or whether it's in India or Africa. I think we have rural part of the country which need ophthalmology, would like to have some refresher course on ophthalmic trauma training. And then you mentioned ophthalmic simulator, and I'm thinking of something to do with the artificial retina. I know unless the photoreceptor layer only is affected, artificial retina has been tried in RP and other degenerative disease. But I think for trauma, we don't have anything, and we have to work on something on bionic eye. I know the second site has gone bankrupt. Now Germany is working something, Australia is working something. Maybe they worked on brain implant, and that also the company has gone. But I think we have to work on something to do with the biological, retinal stem cell, and also genetic engineering will not come in this, but I think bionic eye will be maybe an answer for some of the trauma. So I think with this, I think we have to have a 10-year vision, and instead of calling only an APOTS vision, why not we have the 6 societies together as the global task force, which Rupesh is talking. Maybe have a 2-year to go through all this, because 1 year will be Dr. Tamara will be busy as the president of AAO. Trauma is not the only thing. She will do the entire ophthalmology. And I hope that from AAO gives support to ASOT, APOTS, ISOT, and APTO. So with this, I hope, I know ISOT is the apex for everything, but we have some what do you call difficulty in having some local service. Each AO or APOTS, we have a excellent office support, which I think we have to give to ISOT, which I think this task force can take it up, so that whatever handicap parents has, all of us can put our might and help along with the AAO to make ISOT as the apex, and under which we have this global task force. Parents, you're agreeing? Okay.
Man to that.
Good.
Anybody else with closing comments? And then I'll let Kendrick and Rupesh end it with the plan they're going to have for the global task force. Then we can start working with the research societies. Go ahead, Rupesh and Kendrick.
Yeah, before that, I think I request Tamara, you can think, I know you'll have, trauma will be, you have 12 months. And I think each month you have some targets in academia, I know that. So contribute sometime and tell us what you want us to do. We will do the homework for you. And as a president AO, you can present it to your team and we can collaborate.
All right, that sounds good.
Okay.
Henrik?
Yeah, thank you, everyone. And thank you for giving me the chance to speak. So I think what we need to do is consolidate all the opinions and also to set up a task force. So I think we need to focus on coming up with maybe a curriculum or a induction course in terms of what are some of the basic skills that we need to train. And I think we can start from the basic beginning. So when these residents come into ophthalmic training. The other thing is I think I'll plan with Rupesh to start writing up a commentary on all the different opinions and all the different factors that we've discussed today. And then we can go from there. So I think, yeah, it's going to be a great year ahead and look forward to working with everyone here for this. So yeah, we'll need your help. Dr. Rupesh, do you have anything to add for this?
Only a few words. I think it's the beginning of a journey, and I'm really thankful to everyone and all the mentors here. So look forward to travel this journey together with all of you. I think this is just the start, but we have to travel and probably carry along.
Yeah, hope travel starts again soon, so we can see everyone in person.
Hope so. Hope so. I'm really. I mean, otherwise I was traveling every 2 days, and I'm.
Well, if you are thinking about the rules, the COVID rules changing for this year, I have a joke for you.
Yes.
So, an elderly gentleman has a prostate surgery, and as he's taken to the OR, he asks the surgeon, "Are you the one who is going to operate on me?" And the surgeon says, "Yes." So be careful, please. So after the surgery, the gentleman calls the doctor and says, "How did surgery go?" He says, "Very well. Can I ask you a private question?" "Sure." About my sex life. Is it going to be the same now after the surgery?" And the doctor says, "Yes." And the patient says, "That's too bad."
Friend, I've got to, after that joke, I feel like I can actually do this. I was going to wait till we stop streaming, but you talk about your gray hair, but I want to just share with you here that you bear a striking resemblance to this guy right here. Wait, let me get him here.
It's the
And I want to challenge you because I've never seen the two of you in the same room. So I'm pretty suspicious that you are actually this guy.
the Dos Equis guy.
I wish.
I'm sure that's you.
I think he has cognac in his hand, so I would gladly switch places.
And a cigar, yeah.
Beverage of choice. It used to be Dos Equis. Now he's gone over to whiskey. So.
Yeah. Dr. Kuhn can have a statement. He can say, "I don't usually do ophthalmic trauma, but if I do, I do it pole to pole."
There you go.
Of course.
That's what we need. We need a good celebrity spokesman.
Right. Well, maybe one from top sports, cricket and basketball and soccer and,
Wearing eye protection, of course.
Absolutely.
Yeah.
I know we are all over time and really appreciate the enthusiasm that all of us have. This was planned to be about a 90 minutes to 120-minute session. We've gone on to 3 hours. And I really thank you for the energy and enthusiasm. We could go on, but I think to be fair to all the celebrities we have on screen, I think we had a very, very good meeting. We had good observations, lessons learned, starting off with Huayan from China, and how they really overcame the hurdles to the European experience. Dr. Talma, as always, I enjoy your slides, Dr. Talma. And believe it or not, you have really highlighted the excellence in South African ophthalmology and the pitfalls as well. And it's all about bridging the gap. And I think whatever happens in South Africa, we want it to happen to the rest of Africa. At this point of time, we still see it as a continent and as a good opportunity to work with partners in the rest of Africa. And of course, Latin America, I had the pleasure of going there, and the warmth and the hospitality. And I think I see the Latin American ophthalmologists as one community in one country almost. That's how wonderful the continent is, really, really. And I only hope that we take all the discussions that we've had through Kendrick and Rupesh should really take it forward, have something really constructive, and how the Academy has probably every month has a different glaucoma, retina, vision, all these things. I suppose there's one for trauma, and we hope that at that particular month when the American Academy of Ophthalmology plans a trauma month this year, we will all come back together again, see and show what we've delivered, and we'll probably have a true deliverable by that time. Kendrick and Rupesh, you promise?
Yep.
There you go. Anybody else wants to say anything? Yeah, so that's all. And we will close, if you don't mind.
Yeah.
I think
Thank you.
all the
Thank you, everyone.
Yes.
May I ask something?
Take a picture, please.
Thank you very much for the great meeting. But I would like to knock on the door of several of you for help.
Yes.
If we want to coordinate a proper coordinated African society. Maybe different objectives than the first world, but I think it's so vital. There's 1 billion patients and they really need help. And I think we will need some help of yours if you're happy to do so.
Sure.
be selected.
Actually, Dr. Jan Talma, I told you, your junior colleague who's on maternity leave, Dr. Sanita Mudle, we both did a survey together and I suggested to her already, and she called me as a patron or something like that. I said, don't want. And one of my fellow is there in, I forgot which country now.
I spoke to her earlier this morning and she sent me an SMS just now.
Okay. So, no,
Yeah.
I'm telling her to make a.
I make her do it.
I know you have 52 countries in Africa, which I already calculated, and I'm going to get one from each. And I'm also in touch with the African Ophthalmology Council through the ICO. When unfortunately we couldn't meet in Cape Town. Otherwise, the AOC, the African Ophthalmic Council, I've asked for, we have communicated, and I think because of this in between COVID, I think we're quiet. Maybe we should have a webinar only for Africa, the entire Africa. Maybe Rupesh and Ganga can think about it. APOTS to be there, but speakers should be only from Africa. John Talma, we will work with my Syed Asghar Hussain is there. I forgot which country he's in. He's active. He said he'll call from other countries too. I was there in Ethiopia also 2 years back. So we'll do that. And I think American Academy also has contacts in some of the African countries. So we can have one for the AOC.
Thank you very much.
Okay.
You certainly have my support, Dr. Talma, our support and my support.
Sure. So 3 cheers to all the present, right?
Take a picture, Dr. Rajan. Take a picture together.
Yeah, let's take a picture.